Hello everyone, I welcome all attendees again in another interesting day of pathology sessions. Today we have two sessions. In the first session, we have two lectures of Dr. Abbas Ghemi about head and neck pathology. Each lecture would be of 35 to 40 minutes, and after both lectures, there will be a question and answer session of 10 to 15 minutes. Before the start of this lecture, I would like to say a few words about Dr. Abbas, who is currently working as professor of pathology at University of Erlangen in Germany. He has authored and co-authored over 450 peer-reviewed publications. In addition, participated in several books, including 10 WHO book chapters. His diagnostic expertise and research focus are in the fields of head and neck pathology, soft tissue tumors, GI stromal tumors, renal pathology, pathology of hereditary cancer syndromes, and molecular pathology. He is serving on the editorial boards of several pathology journals, including Modern Pathology, Advances in Anatomic Pathology, Histopathology, and Annals of Diagnostic Pathology. He is a regular invited speaker at national and international meetings. And today his first lecture would be recent advances in sinonasal pathology and molecular correlates. And second lecture would be recent advances in salivary gland pathology and their molecular correlates. Now, screen is over to Dr. Abbas.
Hello, everybody. Again, it is me speaking this time on sinonasal tract malignancies with respect to the recent advances in their classification. We know that the sinonasal area has been the focus of many recent studies dealing with different types of malignancies and their molecular backgrounds. And it is very difficult to cover this topic even in 1 hour or more, so I should focus on only part of it. We know that in the category of adenocarcinoma, we have some new advances in non-intestinal low-grade adenocarcinoma, where two variants have been recently recognized, both of them showing the same translocation. However, one showed the features of salivary type secretory carcinoma or mask. The other one was the classical tubulopapillary adenocarcinoma with the same translocation. On the part of squamous cell carcinoma and variants, now we recognize two variants of HPV-associated sinonasal carcinomas, one of them classically recapitulating oropharyngeal carcinomas with basaloid non-keratinizing morphology, and classical HPV high-risk groups like 16, 18, and so on. And the other much less frequent group is a very unusual high-grade malignancy by histology that shows multi-phenotypic features recapitulating one or many of the types of salivary gland carcinomas and myoepithelial malignancies. So the term multi-phenotypic carcinoma has been coined and now accepted by the WHO classification for these tumors. And in contrast to the classical HBV variants, they tend to have the rarest variants of HBV like 33, 52, 56, and 31, etc. Now coming to the mesenchymal category, we have B phenotypic sinonasal carcinoma with classical MAMIL3 or PAX3 fusions, and also the adamantinoma-like or epithelial variant of Ewing sarcoma with classical EWS FLY1 fusion or ERK fusion. Still, there is some controversy whether these are sinonasal basaloid carcinomas with Ewing translocation or real Ewing sarcomas, but it is not our topic now. I will focus on the topic of undifferentiated or poorly differentiated carcinomas, and we know that in different organs, this topic has been well delineated now, increasingly also in the sinonasal area. And we know that undifferentiated carcinomas usually do not show morphological evidence of differentiation like sinonasal undifferentiated carcinoma are related entities. These entities have sufficient genetic hit or background or mechanism from the very beginning, so there is no differentiated starter component. And in this context, it is important to recognize that a very limited tissue biopsy and the resection specimen are showing exactly the same pattern because these tumors are undifferentiated by definition. So more tissue does not help more unless you have in the biopsy crush artifact or something like that, but you cannot expect more than what you have seen in the biopsy. On the contrary, dedifferentiated carcinomas show a transition from a differentiated to undifferentiated component. So in such a case, we can recognize them better if we have much more tissue. And in the resection, sometimes we reverse or revise the diagnosis to dedifferentiated carcinoma, beginning or starting from squamous cell carcinoma or any other salivary type carcinoma. So in this group, the dedifferentiation is a multi-step or double or triple hit mechanism, and more tissue is helpful. The first category of undifferentiation mainly comprise some tumors like those associated with Sniff gene defects like SMARCB1 or A4 deficient carcinomas, not or not associated carcinomas. They are usually undifferentiated but may show focal squamous features. Oncogenic viruses usually also interfere with differentiation of the cell, so we have usually either undifferentiated or non-keratinizing basaloid monomorphic carcinomas and others as well. No intratumoral heterogeneity, no bizarre looking or giant cell with this much nuclei. If we see something that's very bizarre looking, usually this is not associated with a specific genetic background. Most of them are highly aggressive with the exception of the multi-phenotypic sinonasal carcinoma. This is the group from Virginia who described in 1986 for first time an entity called sinonasal undifferentiated carcinoma as being distinctive entity, not as a final common pathway of dedifferentiation and not as a descriptive diagnosis, but as I said, this is a distinctive entity originating from the Schneiderian mucosa or the sinonasal mucosa. This is the original publication, very large anaplastic cells with very prominent nucleoli forming irregular communicating strands, or some ribbon-like, a little bit neuroendocrine, large cell carcinoma-like here, and again, the anaplastic large cell pattern. Very highly aggressive course, most of them died within just a few months or 1 year. This is a classical example of sinonasal undifferentiated carcinoma showing exactly the pattern we see here in black and white, here in colors, but exactly the same cytology and the same architecture. However, the problem is that thereafter, most people called anything that is undifferentiated or undifferentiated looking, or for them due to limited access to immune or molecular, they call them undifferentiated or sinonasal undifferentiated carcinoma, meaning that these are undifferentiated sinonasal carcinomas and they became SNAC, and the category became very heterogeneous and just like an epidemic. These are one of the examples. For example, I have seen a few years ago, it looks like sinonasal undifferentiated carcinoma, very large cell in some irregular nest, a few inflammation in the background, but only septa-like, very prominent nucleoli. It can be put or pushed into the context or in the spectrum of sinonasal undifferentiated carcinoma. However, it shows by immunohistochemistry classical squamous cell phenotype or differentiation. And of course, this was also EBV positive. So this is an less inflamed or lymphocyte poor nasopharyngeal type lymphoepithelial carcinoma presenting within the sinonasal area. We have to omit it from the sinonasal undifferentiated carcinoma pattern. Not midline carcinoma, the term midline has been now removed from all WHO classifications to avoid under-recognizing it due to that committed term, because not carcinoma can develop in any site, not really limited to the midline. We see that half of the cases of all nut carcinomas are head and neck, and half of them are sinonasal. So it is a very genuine differential diagnosis if we are dealing with something strange looking or unclassified in this area. This is the prototypical nut carcinoma with this abrupt clear cell type squamous differentiation. However, this is seen in no more than 43% of cases, so it is not reliable. It is not sensitive to think of nut carcinoma, just only looking for these features. And we see that the periphery looks very basaloid, undifferentiated, looking. This is the small cell variant, which looks very small cell carcinoma-like. However, if we exactly look at the nuclei, they are not really small cell carcinoma-like. They are not odd cell-like, but they are lymphoma-like. They are very rounded, very small, very uniform, and we see very frequently in this small cell pattern, this is stromal mucoid reaction, which is a very good clue for diagnosis in some cases. This is a large cell snake-like pattern with very huge nuclei, very prominent nucleoli, showing irregular nests and trabeculae, so not really distinguishable from sinonasal undifferentiated carcinoma. We know that most of nut carcinoma are squamous in phenotype. They express P40 or P63 and variably cytokeratin 5. However, some cases may be only focally positive or even completely devoid of P40 and P63. So we cannot rely on it as sensitive marker. It is not that 100% sensitive. The most diagnostic and important marker is the nut monoclonal antibody, which is very distinctive in showing punctate or dusty or granular nuclear expression with very small granules within the nucleus. Some are over-stained, some are less stained, but only the neoplastic cells are positive. So with this feature, we can say this is a definitive case of nut carcinoma. Really, we do not need any more investigation or molecular. So these are the main features. We need the morphology, the P63 if present, but we can immediately look for the nut antibody. If it is positive, we do not need any fish or any other additional stainings. The next group of sinonasal undifferentiated carcinomas have mainly defects in the chromatin remodeling complex, the Sniff pathway. And we know that more than 20 genes have been identified in this complex. However, in the sinonasal areas, we just like to see SMARC B1 and SMARC A4 very rarely, and therefore I put it into gray, ARID1A, but it is not really a relevant marker. The two are very important, and these are tumor suppressors. So if there is a mutation, it is loss of function mutation, and the neoplastic cells should be negative, and the normal expression will be seen in the stromal cells in the background, which is the best internal control. We are also very happy to be the first group who describes this entity at the same time or very shortly thereafter. The group of Dr. Bishop described it, and later on we also together published a very large pooled series of cases. These tumors have a very varied morphology from case to case, but in the case usually they are very uniform. We have this very frequent 70% of cases are basaloid, blue looking, papilloma-like or exophytic or invasive. So all these tumors looking like this are invasive. We should not consider them in situ because they look like a papilloma, because the stroma is very reactive, is desmoblastic with vascular proliferation, and the tumor grow everywhere along the pre-existing epithelium. This is the invasive component, which shows the classical invasion pattern with desmoblastic reaction. Most of cases have been called basaloid non-keratinizing squamous carcinomas in the past. If we look exactly, we see at least in some areas a few anaplastic rhabdoid-looking cells. They may be more prominent in the metastasis occasionally, but they are not very frequent and usually very subtle. We have to look for them if we think of that entity. A small subset of these cases may be more pinkish or sarcomatoid or adenoid, and some of these tumors have been later or reclassified as being genuine adenocarcinoma variants. This is the molecular feature of them. Most reliable is the immunohistochemistry, because the fish may recognize deletion of SMARCB1 gene signals in no more than 2/3 of cases, and NGS panels do not really recognize most of the mutations. So immuno is the most reliable tool. And then the second variant, which has been called gland forming or adenocarcinoma with SMARCB1 loss. This is very interesting to see that it usually may show more oncocytoid or plasmacytoid myoepithelial-like cytology. They are uniformly high grade. They have variable tubules or cribriforming and mucin forming, and very frequent feature, but usually variable within the tumor is the yolk sac-like features or foci, seen in 25% of cases, but might be in more than that if you look exactly for them. Immune is not really very specific, so the most important thing is to exclude other entities, to exclude intestinal type adenocarcinoma because focal CDX2 expression might be seen and CK20 as well. And of course, to exclude genuine germ cell neoplasm in the young because these tumors are SAL4 positive, usually negative with all other markers like OCT3 and 4. And other markers are very focally positive, so they are not usually diffusely positive for SAL4 or for HEPAR1. These are examples from the series we published, very intestinal-like here associated with other variants, intestinal-like or cribriform-like, mucoid, yolk sac-like, sieve-like pattern here again as well. And then you see even the secretory endometrium-like yolk sac pattern in this case associated with very prominent SAL4 expression. This is one case I have seen recently, completely looking like this, just like reticular microcystic yolk sac-like pattern, very uniform cytology, again at high power. And here again, your microcystic reticular-like, and you see very few CK7 positive cells, however, diffusely positive this case for SAL4, and patchy for Glipican and AFP, and complete loss of SMARC B1 is seen. If you have any neoplasm that look like germ cell and you have loss of SMARC B1, this is almost never genuine germ cell malignancy. Then later on, we recognize another entity that looks a bit similar, but with much more larger undifferentiated morphology. And this was found to be SMARCA4 deficient. And these are examples from the publication. We have shown very snake-like, indeed, some of them here and there with nesting. However, some of them are frankly rhabdoid, others are neuroendocrine or high-grade olfactory-like with some pseudo-rosetting. And they are similar to SNAC, completely negative with CK7 and CK5. So they are completely undifferentiated. SMARCA4 loss is the classical marker in these tumors. If you look at this review we published recently, we see that the patient age is a bit different. SMARCA4 deficient tumors tend to be a bit younger than SMARCB1 deficient, but somewhat older than not carcinoma patients. And if you look at the death of the patient, it is very important to note that not carcinoma is at the end uniformly lethal. However, SMARCA4 deficient cases are much more lethal than SMARCB1 deficient and the SNAC as a whole group. So it is really important to subtype these tumors based on these phenotypic and molecular features. It was very surprising to note recently after our series on the carcinoma with SMARCA4 loss that even teratocarcinosarcoma as multi-phenotypic, very polymorphic malignancy indeed was in most part up to 82% driven by SMARCA4 inactivation, and they do not have any other mutation in other cancer genes, so indicating SMARCA4 loss is the sole driver of these tumors. These are examples with the classical embryo-like clear cell squamoid areas. We have the primitive stroma, we have the neuroplastic type, primitive differentiation, we have the strap cells indicating rhabdomyoblastic differentiation, gastric foveolar type epithelium, and tubule with fetal phenotype or pseudo-rosette or ependymal rosette-like fetal tubules. And these tumors are either completely negative with SMARCA4 or partially negative with some retained expression in the small primitive neuroplastic-like areas. So this is very interesting. This case is just to show you that pancytokeratin is not sufficient to diagnose the malignancy as carcinoma in the sinonasal area. If you look, this is a 19-year-old male, so this is not the age of any carcinoma types in the sinonasal tract. We have synaptophysin and CD56. This can be small cell neuroendocrine carcinoma. Still, it is not the typical site or not the typical age for this patient because carcinomas in this age group are vanishingly rare. However, this is alveolar type solid rhabdomyosarcoma with classical features by molecular and with desmin and homogeneous myogenin expression. We have always to think of these cytokeratin positive carcinomas, mainly adamantinoma-like Ewing sarcomas, uniformly cytokeratin positive, maybe also B63 and cytokeratin 5 positive, And most of alveolar rhabdomyosarcoma cases with solid growth, especially, are cytokeratin positive, but these are usually completely different patients than we see in carcinoma cohorts. For example, here, if you have the resection after an undifferentiated or basaloid looking undifferentiated carcinoma, might be you recognize a small focus of well-differentiated squamous cell carcinoma, then diagnosis can be reversed to dedifferentiated or heterogeneous differentiated squamous cell carcinoma with anaplastic component. So this is not a SNAC and not a SNAC-like. We see the immune here as well. Another example is small biopsy from sinonasal looking very much nested with large atypical cells, very similar to SNAC as we have seen before, very brisk mitotic activity. However, if you look at low power, there is myoepithelial-like pattern with increased lobulation at the end and central necrosis in the lobules. This is very suggestive of myoepithelial pattern. SOX10 was then positive, S100 as well mostly. And this is the resection. It looks like high-grade chondrosarcoma, but it still have some cribriforming and adenoid cystic-like features or basaloid pattern. Here again, looking like high-grade carcinosarcoma. These are multi-phenotypic sinonasal carcinomas with HBV infection, and this particular tumor was diffusely positive for P16 and has, of course, HBV33. They are only very rarely HBV16 and 18 positive. This is a seminal series by Dr. Bishop on this entity with adenoid cystic carcinoma-like component, but this is not usually present, so we have to think of them if any high-grade looking salivary type malignancy in the sinonasal tract is seen. If we eliminate all of these entities, the specifically definable by genetics, those with cytokeratin expression but are mesenchymal, etc., then we see that the basket became much more homogeneous, but is still not really completely homogeneous. And we go back to the description of sinonasal undifferentiated carcinoma. Is it an entity or a pattern? We see that this really is exactly recapitulating the initial description of the entity. However, we see a few of studies published recently showing that sinonasal undifferentiated carcinoma frequently show mutation in IDH2 in up to 55% of cases. In this primary study from Boston, later study showed up to 80-85% of cases. And we see that patients with IDH mutations are a bit younger than those without. And among those without mutations, different types of molecular markers were found, like SMARCA4 in one of the 4 cases, and other mutations as well. And the authors of that paper from Boston commented that the morphology and immunophenotype is not really different between the IDH mutated and wild type tumors, which I don't think is exactly correct, because if we look at their publication, you see here, this is the publication from this group. You see that the mutated cases are much large cell, much paler, maybe large cell neuroendocrine-like in some areas, while the wild type are much more blue cell or basophilic. So these are really mostly in the spectrum, maybe either of nut carcinoma or SMARCB1 deficient sinonasal carcinoma. So this is really just a historical SNAC category or cohort and not a well-diagnosed cohort showing exactly the same features. And I think many will agree that these images are completely different from these 2 images, indicating that IDH mutation are more akin to the prototypical historical original description of SNAC as an entity. We see here again the original description and the IDH mutant images. We see that they are exactly very similar. This looks exactly like this, very similar to large cell neuroendocrine carcinoma, and here the large cell pattern with pale stained neoplastic cells. Take home message from these few comments is that the poorly differentiated category of sinonasal malignancies has been undergoing a very dynamic re-evaluation and splitting. We have to separate cytokeratin positive non-epithelial malignancies, as I said. We have to subtype the remaining poorly differentiated genuine epithelial malignancies based on their phenotype to separate squamous cell carcinoma, poorly differentiated Then to look for etiology to separate oncogenic viruses like HBV and EBV, and then to subtype the remaining based on the molecular phenotype into, for example, Sniff deficient or not rearranged carcinomas, etc., etc. Any expression of specific markers other than pankeratin indeed argues against true SNAC because these are undifferentiated. They do not have markers of adenocarcinoma and not markers of squamous cell carcinoma. Then at the end, we come up with an etiology or genetic-based approach to classify these tumors. And indeed, this is now the approach which is adopted in the current WHO classification, in the upcoming WHO classification. And by the way, this approach is the tendency of the WHO in general. For all other organ entities, they are adopting, as far as possible, a genetic-oriented approach. This does not mean you have to test for genetics always, but you have to put the entity into that genetic category by morphology, supplemented by immunophenotyping, by some molecular antibodies as well. And we have to recognize these different types of mutations, either by immunos or by molecular testing if necessary. And now the category of Sniff deficient sinonasal malignancies, which I have the pleasure to write for the upcoming WHO classification, contain 3 different variants. The SMARC B1 deficient category showing either non-descript carcinomas or undifferentiated carcinomas or adenocarcinomas, and the SMARC A4 category including either undifferentiated carcinomas or teratocarcinosarcomas. So in each of these 2 genetic groups of the same category, we have 2 different variants recognized now as distinctive entities. If we use this criteria very strictly to approach these cases, then SNAC will likely represent a distinctive entity, in most cases driven by IDH2 mutations. This is just an overview to show you how we approach these tumors nowadays. We have to be sure, is it a carcinoma or non-epithelial, because we may have expression of epithelial markers in many of these other non-epithelial entities. Then if there is any phenotype of being squamous or glandular, if excluded, then there is keratinization or no, lymphoepithelial or not, and then we have to use the immunohistochemistry like not antibodies, SMARC B1, SMARC A4 as well. We also have to exclude poorly differentiated large cell and small cell neuroendocrine carcinoma by specific markers, and at the end we can put these tumors exactly into one of these categories, really not using more than 5 or 6 immunostains in general, and in individual cases even with much less limited immunopanel. So this is my last slide, and thank you for your attention, and would be glad to answer any question that you may have. Thank you very much. Yeah, Dr. Mudassir, and the organizer of the Shaukat Khanum Cancer Symposium this year. Thank you for inviting me to participate as every year. I'm very honored and very happy to be part of this. And we hope that the next time it would be a physical conference in your beautiful country. The first talk I'm going to give is about recent advances in salivary gland pathology and the molecular correlates of that. I have only 25 minutes, so I have to hurry up a bit, or maybe I may be needed to jump or some slides, but we'll see what about time. So just at the beginning, I'd like to share with you this overview of the very recent WHO classification from 2017. And we see in that classification, there were 22 carcinoma types, and of these, a few were new, like salivary duct, secretory carcinoma, and some benign lesions have been included, like sclerosing polycystic adenosis and nodular oncocytic hypoplasia as well, which were not included in the prior classification. We know that since that classification, a lot of knowledge have accumulated concerning individual entities. So these are just new development in these pre-existing WHO entities, like in actinic cell carcinoma, intraductal carcinoma, also in salivary duct carcinoma, a few information became available, and of course, secretory carcinoma, etc. Most of this new information or data concern the molecular pathogenesis or molecular variants of the non-carcinoma entity, so they are not really new entities. We know that sclerosing polycystic adenosis is now considered a benign true neoplasm, so it is now called sclerosing polycystic adenoma and not adenosis. Oncocytic carcinoma is going to disappear because this is really not a reproducible entity, and we know that in the salivary glands, every carcinoma variant can, on occasion or rarely, show oncocytic phenotype or morphology. So oncocytic carcinoma usually may represent variants of mucoepidermoid or salivary duct carcinoma with oncocytic morphology or cell type and not an entity for sure. Now we have the current WHO classification being prepared. Everything is submitted, and this classification is going to be printed or available hopefully within a couple of months or during the beginning of the new year. And in this classification, there have been also incorporation of all of these new molecular features and newly defined variants in salivary glands, but also in sinonasal and other organs of head and neck. And in the salivary gland carcinoma list, we have 3 new members. It is the sclerosing microcystic adenocarcinoma that looks like skin adnexal carcinoma, but originates not from the mucosa mainly, but from the salivary glands, usually from the minor. And then we have microsecretory carcinoma, which has been reported very recently in 2 series, and mucinous adenocarcinoma that was originally or historically included in the spectrum of adenocarcinoma unclassified or NOS. Now it is considered a distinctive entity. We know that oncocytic carcinoma is going to be eliminated as a specific entity. Regarding the most frequent variant of salivary carcinoma, mucoepidermoid carcinoma, there is really no much new information. However, now most of head and neck pathologists and others agree or tend to classify these tumors based on specific molecular features in addition to the classical morphology, and the high-grade variant of aggressive mucoepidermoid carcinoma is going to be much diminished because most of these historical grade 3 mammil 2 fusion negative cases likely represented adenoid or adenosquamous carcinoma or adenoid variant of squamous cell carcinoma. So it is not now very much welcome to overdiagnose high-grade fusion negative mucoepidermoid carcinoma anymore. Some of these lesions likely also in the previous studies represented mucin-forming hyalinizing clear cell carcinomas that may be very similar to mucoepidermoid carcinoma sometimes, and they of course have the EWSR1 fusion and not the mammil 2. So if we strictly consider the very restrictive diagnostic approach to add to mucoepidermoid carcinoma, almost virtually all cases are going to show the classical translocation of mammil 2. So we have to follow on this new development to see if really there is any true prognostic value of the translocation, which we do not believe now anymore. One of the most important highlights in the previous head and neck WHO classification was recognition of secretory carcinoma as a distinctive entity. And these lesions, we know that have been linked or they are very similar to the secretory carcinoma of the breast. This is why Dr. Skalova and Michal initially coined the term mammary analog secretory carcinoma with the acronym MASC for this entity. Now, in the recent WHO classification, mammary analog has been removed, so it is just secretory carcinoma or SC. It is very important to see or to notice that this is a canonical translocation, the ETV6 NTRK3 or very rarely NTRK2 fusion characterize these tumors and it is very important to be aware of that. If we look at the historical category of acinic cell carcinoma, with which most of the secretory carcinomas have been confused in the past, some 10 to 20% of acinic cell carcinomas were indeed secretory carcinomas that displayed follicular-like, cribriform-like, cystic or macrocystic pattern, etc. It is important to recognize secretory carcinoma because of three main differences compared to acinic cell carcinoma. The first one is that they tend to be more aggressive than acinic cell carcinomas. So 1/3 of cases recur locally, 15% go to the lymph nodes, metastasizing to the regional lymph nodes, highlighting the need for neck dissection in cases with secretory carcinoma diagnosis, and 15% of patients may die of disease, which is much, much higher compared to the classical acinic cell carcinoma. Also, another important point when thinking of grossing secretory carcinomas is to recognize their tendency for high-grade transformation. So these lesions should usually or ideally be sampled completely to avoid missing any aggressive high-grade clone. Another important point, those tumors that recurred locally are not resectable or metastasized to the lung or other distant sites. They can be very well treatable by NTRK inhibitors like larotrectinib and other recently validated drugs. This is the classical image from Dr. Alina Skalova publication. This is the typical, prototypical pattern of secretory carcinoma, irrespective of being in the salivary or in the mammary gland. We see this very minute lumen-forming sieve-like pattern, invasive growth pattern, very monomorphic nuclei, and these tumors might be infiltrating or well circumscribed and encapsulated. However, we have some other variants that look much more solid. They have very uniform cytology and some mucoid secretion in these small lumens and even maybe intracellular. So these tumors might as well be confused with solid variant of mucoepidermoid carcinoma. We know that very recently a very deceptive variant has been described as macrocystic by the group of Dr. Wenig, and these are essentially comparable from a demographic and other aspect to their classical variants, but they are predominantly macrocystic, composed of a single or multiple large cysts. Mainly they are in the parotid gland, which is indeed a contradictory aspect compared to their classical variants, which are very, very frequent in the minor salivary glands. And we see that some of them may even have a peripheral P63 positive layer. So it might be in part an intraductal variant of secretory carcinoma. Some of them may recur locally or even rarely metastasize. And this is the very deceptive appearance of these lesions. It looks like just a ductal cyst. However, frequently we have at least a minor intraluminal component either swimming within this secretion or adherent to the cyst wall, and sometimes look like multicystic cyst adenoma with very bland looking epithelium. This is another example from my cases. You see also it looks like intraductal proliferation like a papilloma or low-grade intraductal carcinoma. However, the immuno is very helpful in these cases because we have a very conventional marker constellation of secretory carcinoma. They co-express SOX10, S100, mammoglobin, MAC4, and in addition, CK7 and vimentin are very frequently positive. If they contain the classical translocation, then they tend to show a nuclear expression of PANTREC. This is an example from the oncology literature just to show you how it is important to separate secretory carcinoma from acinic cell carcinoma. This patient who was historically diagnosed with acinic cell carcinoma of the parotid developed a couple of years later extensive lung and pleural metastatic disease. However, diagnosis was revised to secretory carcinoma because the diagnosis was preceding the description of secretory carcinoma as a distinctive entity. So any historical acinic cell carcinoma case should be very critically reassessed to be sure it is acinic cell carcinoma and not secretory. So if we look here, after 9 weeks of NTRK inhibition therapy, this neoplastic mass almost disappeared completely. So this is a highly effective treatment for these tumors if they have this translocation. The question would be, is it sufficient to look for secretory carcinoma diagnosis just using the ETB6 fish, which we know it is very well functioning and widely available? The answer is unfortunately no. You can confirm diagnosis of secretory carcinoma with ETB6 fish, but you cannot tell if this exact tumor is going to respond to NTRK inhibition therapy or not, because a subset of cases do not have NTRK but RET as gene fusion. And for this subset of cases, if there is any oncological indication for systemic therapy, as in metastatic disease, for example, then we need RET inhibitors and not NTRK inhibitors, which are not going to be of help. So it is very important to know exact genotype. The pan-TRK immunohistochemistry, sorry for mistake here, or misspelling, is very helpful if it is positive. However, we have to be careful because I see that different antibodies are different positive in different laboratories, and some are staining everything. So the antibody we use is very specific for secretory carcinoma with NTRK fusion. It shows a distinctively nuclear staining. However, we know that the same antibody stains the cytoplasm is in NTRK fusion positive mesenchymal neoplasm or sarcomas, as well as some colorectal carcinoma, for example. So we have to be very careful with interpretation of the immunohistochemistry. If we have S100 positive, MAC4 positive, this is very helpful because S100 expression precludes actinic cell carcinoma, MAC4 expression precludes intraductal intercalated duct type adenocarcinoma and other mimics, except maybe mucoepidermoid carcinoma. Just to say a few words about actinic cell carcinoma. Of course, this is the only salivary gland carcinoma that very much look like the normal salivary parenchyma. This is a well-differentiated lesion, very rich in zymogen granules. Therefore, it is called also blue cell neoplasm or blue cell actinic cell carcinomas. And we are very happy to identify in these tumors recently through our group a very specific translocation of chromosome 4 and 9. And this translocation, which is very interesting to note, that it does not result in formation of a chimeric protein or fusion protein, but it results in transportation of highly active enhancer genes to be located upstream the NR4A3 gene, and this will result in oncological autonomous overactivation of this proto-oncogene, and the result is the tumorigenesis of actinic cell carcinoma. And based on this overexpression of this protein, we could happily also propose and establish the immunohistochemistry for NR4A3, which is a completely or strictly nuclear staining pattern for actinic cell carcinoma. Until now, this has not been described in any other entity, so it is very helpful to recognize and confirm conventional actinic cell carcinoma. However, usually in most cases, we do not need this immunohistochemistry because diagnosis is straightforward, and we can use, of course, the PAS and the stage-free digestion protocol to highlight the enzyme granules. However, something like this in cytology preparation or even in resection that looks like benign inclusion in lymph nodes or something very strange, these are metastatic actinic cell carcinoma or actinic cell carcinoma with lymphoid stroma sometimes, so they can be confirmed as being neoplastic. And I think the group of pathologists who much benefit from establishment of this immunostain are cytopathologists who can now very easily confirm diagnosis of actinic cell carcinoma in cytology specimen or smears. We see here some type of actinic cell carcinoma that has undergone complete dedifferentiation on transformation into undifferentiated looking carcinoma or malignancy. Still, they retain expression of this marker, so it can be also used to subclassify undifferentiated looking salivary carcinomas. Salivary duct carcinoma is well known since 1968, described initially by the German ENT surgeon and pathologist, Professor Klein-Zasa. and you see the classical pattern with DCIS-like comedonecrosis. And there is no really much new data on that, but only one feature that I am going to show you. This is the classical apocrine type, the DCIS-like with comedonecrosis, the poorly cohesive, diffusely growing variant, and here again sarcomatoid and spindle cell pleomorphic variant. We know that it is not recommended anymore to call such a lesion adenocarcinoma NOS. They are very frequently androgen positive, so they are variant of poorly differentiated salivary duct carcinoma, and it is not mandatory anymore to look for the classical salivary duct carcinoma pattern to diagnose salivary duct carcinoma. So any high-grade adenocarcinoma with or without apocrine features, with or without comedonecrosis, but with some expression of androgen receptor in the parotid gland is salivary duct carcinoma as acceptable diagnosis. This is a HER2 expression, which is very strong in almost 1/4 of cases, corresponding to high-level amplification and, of course, androgen receptor expression. Our radiation oncologist did this study very recently, showing that HER2 amplified cases tend to behave more aggressively than those negative cases. So it has both prognostic and therapeutic relevance. Very recently, we described a series of salivary duct neoplasms showing ALK fusions and reviewed the literature. So a total of 9 cases have been reported to date. And if we look here exactly, most of patients are elderly. They are almost of equal sex distribution. The parotid is most common site. And we see that all these tumors are de novo. So they are not pleomorphic adenoma. And at the same time, they tend to show the classical features of salivary duct carcinoma without atypical features. Atypical features I will show you in a while. We see also a second variant of salivary carcinomas with ALK fusion are intraductal carcinomas of intercalated duct type, but these are not very relevant because we know that they are indolent and usually do not metastasize. However, salivary duct carcinoma is very important to recognize as having ALK fusion because this can be treated by ALK inhibition. If we look here, we see classical features of salivary duct carcinoma, comedotype necrosis, widely invasive, some papillary features here. However, these ALK fusion positive cases tends to show 2 distinctive features. One of them is an overrepresentation of the basal component or basal-like differentiation with squamoid features, and some mucin, either cellular, luminal, or stromal, which is a feature known in many of the ALK salivary duct carcinoma is the most frequent type, followed by myoepithelial and very rarely by carcinosarcoma. Pleomorphic adenoma is usually small, not diagnosed before the diagnosis of carcinoma, and only in few cases we have the constellation of recurrent pleomorphic adenoma. I will just show you some features of this. We have very frequent microcalcifications with gritty sensation upon bisecting the specimen, and this is this scheme illustrated in a series we published recently. We see different steps. We have the very early cytological atypia, then we have the full build of intraductal carcinoma in situ. Then the next step would be intracapsular invasion into the matrix of the pleomorphic adenoma. After that, the extracapsular invasion, which can then be stratified into minor or extensive extracapsular invasion. This is a very early changes with cytological atypia with prominent nucleoli. We have aberrant expression of androgen receptor, maybe some overregulation of p53 or overexpression due to some mutations. And we have at the same time higher expression of HER2 with or without amplification. So these are the so-called in situ or early changes. However, this is a classical intraductal carcinoma without intracapsular invasion. It looks like high-grade ductal adenocarcinoma, however, still bordered by intact basal cell layers that can be highlighted by P63. These tumors cannot metastasize. However, if they go inside the capsule or into the matrix of the pleomorphic adenoma, as we see in this case, they can metastasize, although there is no extracapsular invasion or component. This is a minor extracapsular invasion with a better prognosis. And this is the classical what we see when bisecting the specimen, a well-circumscribed, gritty sensation associated appearance, which is due to dystrophic calcification. This is a pleomorphic adenoma, usually very small, and this is the widely invasive salivary carcinoma. Here again, we see the same thing, small pleomorphic adenoma with very extensive sclerosis and widely invasive salivary carcinoma. Just to show you a few images of high-grade transformation, which we can see here. This is an actinic cell carcinoma with a very classical focal area of cribriform-like microcystic pattern and very high-grade transformation with extensive necrosis area. Another example of adenoid cystic carcinoma showing abrupt transition from conventional cribriform and tubular to solid with comedonecrosis, and this was associated with high expression and amplification of HER2 in this case. Just to show you with this slide, the new entities that are coming in the next WHO classification without showing any details before publication of the fascicle. You see here the malignant lesions that are included now is sclerosing microcystic adenocarcinoma, microsecretory adenocarcinoma, and mucinous adenocarcinoma are the three variants that are included in the benign category. Keratocystoma, which was a lesion in some of the earlier classifications, is coming back into the classification. This looks just like non-sebaceous lymphadenoma with some keratin filces, very overlapping with sebaceous lymphadenoma as well on the other side, but it is a harmless lesion. Intercalated duct adenoma and striated duct adenoma are now also included in this new classification, which will be hopefully published very soon next year. With this, I am at the end of my presentation. Thank you again for inviting me, and we'll be glad to answer any question. And I have to admit, I'm not sure if I will be available on the day of the live conference for any question. Otherwise, we can arrange to answer these by chat or email or some alternative. Thank you very much.
Thank you very much, Dr. Abbas. And always you are one of the best speakers in this part of the world, I think. And there are few questions. So the first question is focal positivity less than 50% of synaptophysin stain is admissible in SNUC, provided other lineage markers are negative?
Thank you, Dr. Mudassar. You hear me well?
Yep.
Thank you very much, and for the invitation again now in person. Yes, I think we have reported variable expression of neuroendocrine markers in SNUC. I do not much focus on the extent of the expression, but on the morphology. So if we have the typical nuclear morphology of neuroendocrine carcinoma, large cell type, and then we have a moderate expression of neuroendocrine markers, I might say this is a large cell neuroendocrine carcinoma. However, without classical neuroendocrine morphology at the cytological or nuclear level or chromatin features of that, then even if I see much more widespread expression of synaptophysin, usually I would not call it neuroendocrine. We see the same thing with some SMARCA4 deficient carcinomas as well in other organs. They tend to express neuroendocrine markers, but morphologically they are not neuroendocrine.
Okay, and the second question is, what is your recommendation of initial IHC panel when dealing with an apparently undifferentiated sinonasal carcinoma?
This is a good question, and of course there is really no minimum panel to be used for all cases. I like to see the demographic features. Is it a very young person or patient? or the classical age of carcinomas. And then the morphology, is it monomorphic or very bizarre looking? And if it is monomorphic, is it basaloid, blue stained, or large cell anaplastic? And based on these different combinations of demographic and classic morphological features, I tend to select my initial immunohistochemistry. So pancytokeratin is frequently required. If the age is not that of sarcomas, we do not need to include desmin, but in the very young, always we have to include desmin. And then SMARC B1, a neuroendocrine marker, of course, and based on morphology as well, the not immunohistochemistry. So if you include pankeratin, P16, P63 or P40, of course, and then SMARC B1, you are going to recognize most of the cases indeed.
Okay, so the last question is, as oncocytic carcinoma has been excluded from the latest WHO classification, but what if there is an oncocytic tumor which doesn't fit as a variant of any other tumor even after extensive sampling, NIHC? Then how should we report it?
I think really oncocytic carcinoma is not an entity, but a cytological pattern. Yeah. Most of the cases we can initially classify as either low grade or high grade. If they are high grade, most likely they are variants of salivary duct carcinoma. And fortunately, they tend still to express androgen receptor and the classical markers of salivary duct carcinomas as well. And if they are low grade, then we have to think of many variants of other carcinomas, but the most frequent one, of course, is mucoepidermoid carcinoma with prominent oncocytic morphology. Very subtle areas, if completely sampled, and sometimes we even perform some stepwise sectioning to recognize very subtle mucinous cell component. If we have any few mucinous cells, it is mucoepidermoid carcinoma. If not, I'm going to test them for MAMIL2 translocation by FISH at least. Otherwise, just call them unclassified carcinoma with oncocytic features.
Okay. Okay, I don't have any other question, but there are many impressions of your praise. So people are very happy that you have delivered your lectures, and I don't have any other question for your answer.
Thank you very much.
Thank you very much again. And I think in the next year, you will be invited personally or physically here in Lahore.
I'm hoping very much to come back to Lahore. Thank you.
Okay. Thank you very much. Thank you very much.
Thank you very much.
Okay, this is the first session of today's pathology program, and the second session will start at 3:40 or 3:38. Please stay tuned or join again at 3:40. And next two lectures are very important and very interesting. One of the lecture is of pediatric brain tumors, and the other one is molecular pathology of lung. And I see you at 3:40 again. So I welcome you again in the last session of today's pathology program. And this is a time for brain pathology. We have just entered into the first lecture of today's last session. And the first lecture would be of Dr. Simon Payne. He is currently working as consultant neuropathologist at Nottingham University Hospital in NHS Trust. He is co-author of over 90 original and review articles, book chapters, and abstracts. Moreover, he is a member of editorial board of Neuropathology and Applied Neurobiology. He has many awards and distinctions like Jean Campbell Award, Royal College of Pathologists, Gold Research Medal. His today's presentation is about challenges in diagnosis of pediatric brain tumors. Now over to Dr. Simon Payne.
Hello, my name's Simon Payne, and it's my pleasure to be able to talk to you now about some of the challenges that we all face in diagnosing pediatric brain tumors. Now, for those of you that don't recognize this chap with the arrow, this is Robin Hood, and he is something of our patron saint in Nottingham. He's famed for robbing the rich to give to the poor in the forest that used to cover this part of the world in the Midlands of the UK. And I thought I'd just show you what my hospital looks like. This is Queen's Medical Centre, or QMC, in Nottingham, and it's perpetually a building site. And this is our lab. I don't know what your laboratories look like. And these are three of our biomedical scientists who do all the hard work. I guess this lab hasn't really changed in many years, really. It's very similar to what you'll find all over the world, but as we'll talk about, that's going to have to change. So I thought that I would talk about some cases where I and we as a team have not got things right. And that's following partly these wise words: always try to learn from other people's mistake, not your own. It's much cheaper that way. And I don't know if any of you recognize that. It's a quote from a very wise man, the recent ex-president of the US. So following those words, what am I going to talk about? Well, I'm going to start with an illustrative case that is etched on my mind and those of many of the treating clinicians here for reasons that will become obvious. And I'm talking about whole methylome array analysis and how essential it is to pediatric neuro-oncology practice, and how it underpins a lot of the new WHO classification, and some of the practicalities of how we use it and the situations that are particularly useful. But then I'll finish on with some cases that show why you still need to be a good pathologist, and whole methylome array analysis or other molecular analyses are not going to solve all of our problems. So this case, this was is a 13-year-old girl who was referred from a regional hospital. Now in Nottingham, we cover a large area, about 4.5 million patients, and there are lots of regional hospitals. So this girl presented to one of those hospitals with seizures and was found to have a right temporal lesion. Now, I hope you can see my arrow, but you can see here that we've got some abnormality in the right posterior temporal lobe that on multimodal imaging had evidence of edema and some concerning features, such that the radiologists, although initially thought to be perhaps a lower grade lesion, commented that this was not typical for such, and that they wondered whether this could be a more aggressive process. So it was resected, an open resection, and this is what we saw. We've got a spindly lesion, quite cellular in places, with quite a degree of nuclear atypia. And in places, it's really quite marked. You can see here some cytologically atypical cells, along with microvascular proliferation. And it looks a bit of a curious thing. We've got these fascicles of cells, and there was reticulin, there's pericellular reticulin. So I was wondering with that setup, and there were quite frequent mitotic figures, including some atypical forms in it, I was wondering whether this could be something like a glial sarcoma. Now, and going against that was the fact this was GFAP positive, very strongly, uniformly GFAP positive. Neurofilament only highlighted, as I'm sure you know, neurofilament cross-reacts with mitotic spindles. So you can see here a couple of the mitotic figures. HRX is retained, no common IDH mutation. Obviously, that would be unusual in a child of this age. And a little bit of parenchymal CD34 staining, but really it was limited to the vasculature. Now, the key wasn't incredibly high, but it was quite high in places. And so I was left with this diagnosis that I couldn't say with confidence what this was, but I did, putting it together with that radiology, whether this could be some sort of high-grade glioma, particularly gliosarcoma. But because of the nagging doubt in my mind, I sent it for whole methylome array analysis. Now, this was a few years ago when arrays were quite new. And so we were getting used to the reports that we got back, which come back with a calibration score, so probability score essentially of what type of tumor it is. Now, the methylome arrays are fantastic when they give you a good score. You can see here, I'll let you read the how to interpret that. But basically, at 0.9 and above, and you're confident, 0.5 and above, less confident. So this score of 0.99 was very impressive. But what was it? What is a schwannoma? And actually, if you look at the literature, there are rare reports, less than a handful, of intracerebral, intraparenchymal schwannomas. And of course, we all know that GFAP cross-reacts with some of the components of the peripheral nervous system. And so I'd fallen into that trap of calling this a grade 4 tumor on the basis of the cytology, the microvascular proliferation, the proliferation indices, but it didn't fit because of that reticulin and so on. And this, I'm sure, is the right diagnosis. And now, 2 years later, the patient remains well with no evidence, radiological evidence of recurrence. So what are these arrays? For those of you that aren't so familiar with them, they are ways of looking at the patterns of methylation across the genome. So this is not the nothing to do with the genetic code itself, nothing to do with DNA, RNA, but it's the patterns of methylation across the genome. And the group in Heidelberg, Andreas von Deimling and co, developed this technique. And what it gives you is a fingerprint, a methylation fingerprint across the genome. And when you match that with a library of known methylomes, it's possible to generate this a probability score as to what sort of tumor you're. Now, this is an incredibly powerful technique, and you can get other data from it other than the probability score. You can look at copy number variations, amplifications, and so on. And it's become very quickly the standard of care in pediatric neuro-oncology because it gives an objective view. So as pathologists, as you know, we predict the future, we're crystal ball gazers. But up until now, this has been very much a subjective business, whereas now we've got something objective, and that's tremendously helpful. And I'll show you some of the ways that that's helpful. Now, this really underpins this technique, and allied techniques really underpin the new classification. I still haven't seen the book, but over the summer, there was this publication from David Erson and esteemed colleagues, which has given us a bit of those of us not fortunate enough to be in on it, an insight into what's ahead for us. And molecular diagnostics are run through this to its very core. And a number of new entities have emerged or are going to emerge in this new classification. Some of these I'll talk to you about. Obviously, some of them, rarer than others. I'll mention these two in particular and show you some cases. So the rest of this talk is really going to be going through cases and demonstrating the use of these techniques, highlighting the challenges that we face as pathologists, and taking some summary points from them. So Beaton. Now this is a fascinating case. 5-year-old boy who presented without any generalized symptoms, but simply with a left-sided head swelling. And he had a CT scan because of this. And then this MRI scan, which shows this incredibly large left-sided frontoparietal temporal tumor, which is causing midline shift and so on, and obviously deforming the skull. Now, of course, a child at 5 skull is deformable, it's growing, and what this tumor had actually done, this has been published by the surgeons here, was to produce this copper beaten effect. So the intracranial pressure had damaged the skull in this way, and as it had grown, it had developed this copper beaten pattern. Now, as a pathologist, when you see something like that, you think, well, really, there's got to be a diagnosis here. The surgeons did an amazing resection and sent tissue on 2 occasions, an initial biopsy and then a more substantive resection. And what we saw was a glial tumor, looks predominantly astrocytic, variably cellular. In some places it was very cellular, in other places it was less cellular. You can see these fascicles of cells and these mineralization, this positive mineral. Now, cytologically, in places it was quite bland, but elsewhere it was more atypical, and proliferation indices I'll show varied again from quite low to quite high. Here we've got some more atypical cells. And this is from a publication that this case is part of. And again, quite a variable appearance. And this is the Ki67 proliferation index, so low in many places, but high elsewhere. Now, immunohistochemistry wasn't helpful, and we were left without a diagnosis. Is this a high-grade tumor, or is it a low-grade tumor? We really couldn't say with confidence. We considered a whole range of diagnoses, including desmoplastic infantile astrocytoma and so on, but weren't able to come up with a confident diagnosis. So we sent this away for whole metalome array analysis, and it came back with, again, a very high calibration score as an infantile hemispheric glioma. Now, in addition to that test, we also sent it for an RNA fusion panel, and this detected an ALK CCDC88A fusion. And that was fantastic news, partly because it allowed us to confidently diagnose this tumor, but it also allowed us, or allowed our clinical colleagues, to consider using an ALK tyrosine kinase inhibitor therapy. And this tumor is one of these infant high-grade gliomas, which has been published. This group have quite happily got the best background to any paper that I've seen of late. And these things form, or develop rather, all over the neuraxis, including the spinal cord, less commonly, but they tend to be supratentorial, but can be anywhere. And they separate out on methylation analysis. So this diagram shows you how the clusters of different methylation profiles form, and ringed at the bottom here, you can see that we've got this infantile glioma, high-grade glioma. Now, these tend to have fusions either in ALK, as we've got, or in NTRK, and of course both of these are targetable pathways. Now, when you look at the survival of these, the presence or absence of a fusion is very important, because it looks as though, obviously the numbers are small and the data's not as unequivocal as you'd want. It looks as though the presence of a fusion is going to be prognostically favorable. So where does this tumor fit within the new classification? Well, it's here, the infantile hemispheric glioma, which is currently under the diffuse high-grade gliomas in this new classification, which splits the low grades with the high grades. So diffuse astrocytomas, low and high grade, and then this third group of the circumscribed astrocytic gliomas, which of course has got things like the pyocytic astrocytoma in it. And you'll notice that many of these have got genetic changes or alterations in their title, reflecting the importance of molecular diagnostics. Now, without that array, could I have told you that this is an infant type or infantile hemispheric glioma? No, not a chance. And without the fusion, then we obviously couldn't have directed our clinical colleagues towards the appropriate therapy. So the next case, and I have to thank Dr. Ed Cheeseman, who is a pediatric pathologist in Manchester, who sent this case to me. One of the joys of my job is to be a review pathologist for a couple of the trials in the UK, including the PSYOP to ependymoma trial. So I see virtually all of the subtentorial pediatric ependymomas, and it's a very privileged position to be in, because you realize how difficult it is to diagnose these things. And we often see, or not often, but occasionally we see things that look like an ependymoma, but end up not being so. And this is one of them. So this is a 5-year-old boy who had presented with a relatively short history of headache and vomiting, and on examination was found to have bilateral papilledema. So these are Ed's images that he's kindly let me use. As you can see, a large hemispheric tumor that has either got a cyst in it, but I suspect is probably related to the ventricle, causing midline shift and hydrocephalus. And the radiological differential was of an embryonal tumor, such as an etma or an embryonal tumor with multi-layered rosettes, or an atypical teratoid rhabdoid tumor. They consider nanoplastic ependymoma to be less likely, but still possible. And thankfully, at presentation, there's no evidence of intracranial or spinal metastases. And this is what the tumor looks like. Now, for those of you used to looking at CNS tumors, you'll notice immediately that there are these blood vessels around which there are these nuclear-free zones, and in places there's an impression of tapering processes, so the characteristic ependymal pseudorosettes. But to my eye, the cytology wasn't entirely correct for that. So ependymoma, you tend to see stippled, oval, relatively uniform nuclei, but we didn't have that. Although in places, these really do look very much like pseudorosettes. And there was this, there was necrosis, and the proliferation indices were high. As you can see here, we've got a couple of mitotic figures. But it was completely GFAP negative. So that really argues against it being an ependymoma, because, okay, there can be quite light in GFAP expression, but you usually see the processes around the vessels, tapering processes expressing GFAP, which this didn't. No synaptophysin or evidence of other neuronal differentiation. Vimentin was positive, and there was some CD99 expression, but no EMA. And this is the key 67, which is moderately high, I would say. So could this be an ependymoma? Now, for the purposes of the trial, I said it could be, but I didn't think it was. I didn't think it was definitely an ependymoma. And this case was sent off for methylation array analysis. Whilst that was being done, the case was stained for B-core, a new antibody to many laboratories, and the array analysis and a fusion panel confirmed the presence of a B-core, a pathogenic internal tandem duplication in B-core gene. So our integrated diagnosis for this tumor, CNS tumor, B-core internal tandem duplication, I'll let you read the rest of it, but basically it captures both the histopathological changes, the CNS grade, which in this case is yet to be clarified, and the genetic information. So again, could I diagnose that without these things? Of course not, of course not. It is very helpful though for those laboratories still relying principally on immunohistochemistry, and I count our laboratory pretty much in that. We don't have the greatest access to methylation arrays. It's taking about a month to get the results back from the centers that we send them to. And that month, of course, is really important. After that Schwannoma case that I presented initially, the oncologists have been unkeen to start radiotherapy planning, because that involves radiation in the form of CT scans, and to start treating or to even just expose a child to a planning scan for a diagnosis that subsequently turns out to be a low-grade tumor is not something they're willing to risk. So we are now in the position of having to wait for a month or so to get that methylation profile result before the oncologist can treat a patient, and that's a big problem for us. So if we can use immunohistochemistry, something like in a few cases, you can get the diagnosis. So an ATRT with loss of iron I1, obviously B-core, an H3K27M mutation. We don't use the G34R antibody. We don't use the BRAF V600E antibody. But in those rare occasions in the pediatric setting, when you can make a diagnosis, a confident diagnosis on the immunohistochemistry, then all the better. So as I was saying, the B-core antibody seems to be pretty accurate in diagnosing these tumors, but time will tell. Time will tell. So I've shown you some cases where methylation array has been of tremendous use in making essentially a molecular diagnosis or a confident diagnosis in the absence of distinctive morphological features, or in the presence of a pathologist who can't diagnose a schwannoma. As a neuropathologist, that's a bit of an embarrassment, but I'm willing to take it. Even in hindsight, I still don't think you could have got that first case I showed you. But anyway, it's a mistake and I'm learning from it. So one of the things that we are going to have to become increasingly is guardians of tissue. When you have a whole range of different purposes for the tissue, be it methylation array, fusion panels, NGS panels, looking for particular mutations, and then of course our own histopathological assessment, we've got to be guardians of tissue and we've got to use it wisely. And that is incredibly important when you have very little tissue. So this was a very little girl, 18-month-old girl who presented, if that's the right word, for not feeding, poor feeding and failure to thrive. So she came through the pediatric services, general pediatrician, and she'd also, by the time she came to our clinic or our hospital, she'd also developed a gaze disturbance. And for those of you not familiar with the CNS imaging, this is quite a tricky one to spot, but it's here on the back of the medulla. So we've got the brainstem here, cerebellum, fourth ventricle, and you can see this thing sticking out from the back of the medulla into the fourth ventricle. And it looked like a relatively benign thing. The radiologist gave a differential of ganglioglioma or pilocytic astrocytoma. And because it was in such an eloquent or essential area, the neurosurgeons were very unkeen to do anything other than a biopsy. Now, I've put on my scale here, and I think that's probably a little bit generous, but we got these two fragments of tissue that thankfully survived processing. Apologies for all the dirt on the slide, that's my fault. Tiny biopsies. And when you looked on high power, they were incredibly bland, clearly more cellular, clearly a mono population of things. We didn't have the normal mixture of cells that you'd find in a normal biopsy of the, I hate to say normal biopsy of the medulla because that's not something you really want to be doing at all. But you can see that there in the center of the picture here is a single Rosenthal fiber. But what I didn't see was the typical architecture of pilocytic, that biphasic architecture with loose microcystic areas and then more dense fibrillar areas. And in places, one of the other hazards here was that there was quite a lot of surgical artifact. So you can see that running through the middle of this image, there are streams of cells that have been compressed and so distorted. Now, one of the great things about the molecular classification is that even if the tissue doesn't look great morphologically, then it's often okay for methylation array. And so in this case, I didn't do any immunohistochemistry. Sometimes in this setting, I might do an H3K27M just to get that diagnosis out of the way. But in this case, it looked very low grade. The radiology was low grade. So I didn't bother to do that. I wanted to confirm, to keep as much tissue as possible for genetic analyses. And so we sent this off rather optimistically for whole methylation array analysis. And I've included here the classifier, which is the maths behind the array, is updated regularly by the Heidelberg group. And so this is a relatively early iteration of the classifier, but it came up with a calibration score of 0.91 for the class, which was pilocytic astrocytoma, and 0.88 for subclass, which is posterior fossa pilocytic astrocytoma. So we've got very bland, low-grade looking morphology, nothing distinctive, nothing that allowed me to come up with a confident diagnosis. Yeah, it's entirely in keeping with pilocytic astrocytoma, but I couldn't have said with any certainty that it wasn't anything else, particularly given the amount of tissue we had. But I can now, because the methylation array has been so helpful in this case. And one of the things that the array also gives is a prediction of whether the MGMT promoter is going to be methylated. Now, I haven't worked out how accurate that is, because we haven't had many cases who've for which we have then subsequently done bisulfite treated PCR, specific PCR to quantify methylation of that MGMT promoter. But it seems to be something that our clinicians at least are pretty willing to act upon. Okay, so the next few cases are cases where everybody was wrong and the array can't help. Yeah, let's get into them. So this is a fascinating case. It's a 12-year-old boy who presented with 12 days of headache and vomiting. It's a short history, and so immediately, for those of you not used to dealing with the nervous system, we put things very much in the clinical radiological context. And so a short history like that, we're going to be thinking, is this some sort of high-grade lesion? Now, of course, you can have lower-grade lesions that, say, for example, are blocked on the CSF pathways, and so have caused a precipitous presentation with hydrocephalus because of a sudden ball valve or similar effects causing hydrocephalus. But typically, it's more likely to be a higher-grade lesion. Now, this was the lad's scans, axial and coronal, and you can see that there's something that appears to be expanding. If you follow the grey matter around, it seems to be centered on the grey matter and seems to be expanding the grey matter. Now, that pattern would be most in keeping with a glial or an intrinsic tumor, at least an intrinsic tumor, and it's associated with an awful lot of edema. So you can see the midline. If I draw a line down there, I hope you can see that. That midline has been shifted quite a lot. So there's quite a lot of mass effect with this. And again, we had our radiologists were able to put a voxel on this and do some of the fancy magnetic spectroscopy, multimodality imaging. And I haven't the foggiest of what this means, but I do know I am able to read reports. And our radiologists, we're very fortunate in radiologists in Nottingham that we have 3, I think maybe 4 now, radiologists, neuroradiologists who have a particular interest in pediatric neuroradiology, and that's a tremendous strength if you have colleagues like that to work with. So they reviewed all the images, multimodal stuff, and came up with this conclusion consistent with a right frontal high-grade glioma. Now, I haven't photographed the smear for you because it didn't photograph very well at all, but Sherlock Holmes said that there's nothing so distracting as an obvious fact, and I think I was misled. Well, I wasn't misled, I got it wrong, but I said that this was likely to be a glioma, or was a glioma likely to be high grade. And so when you give a smear report like that to a neurosurgeon, then what they do is this, so theirs was the tumor, and there's a beautiful, beautiful resection of it. Nice operation. Now, when I got the wax, this didn't immediately strike me as a glioma. It didn't immediately strike me as anything in particular. It was one of those cases where you look at it and you think, this is something. This is something. I don't know what it is at first glance, but it's something. And it looked to have a predominantly perivascular distribution to it. So obviously a vessel in the middle here. And that's expanded, that perivascular region is expanded. Some quite big, quite nasty looking cells, some with a little bit of a rhabdoid appearance to them. And you can see this is the residual neuropil here, or native neuropil that's being pushed away. And so I often find a reticulin stain, excuse me, is very helpful for delineating the architecture, vascular architecture, or if you're wondering about whether something's up into the meninges, then reticulin is very useful. And that shows you exactly that we've got a vessel here, the surroundings of which have been expanded, by this process. It didn't look inflammatory to me. That was the first thing. It looked like tumor. There were areas of sort of incipient necrosis, but there was Again, lots of vessels surrounded by abnormal cells. And when you got on higher power, you saw that it was a mixed population, but really standing out with these very large cells, sometimes with sort of reniform or kidney bean shaped nuclei, often with multiple nucleoli. And this was the best image I could find of these sort of slightly rhabdoid cells. Now, I have a list in my head of things that can look rhabdoid in the nervous system. And one of them, well, I'll come on to that. This is GFAP, which showed me completely confidently that my smear diagnosis was wrong. Lots of reactive astrocytes, which I think is what misled me. Proliferation indices very high. And lots of CD3 positive cells, not so many, but still quite a few CD8. Iron I1 was retained, given those rhabdoid cells. And this is the stain that gave the diagnosis, because anaplastic large cell CD30 positive T cells can be rhabdoid and have that typical reniform nucleus. And these ones happen to be ALK positive as well. So I wondered if that was the diagnosis after I'd seen the immuno, and sent it across to our hematopathologist, who agreed that this was primary anaplastic large cell lymphoma of the central nervous system arising in a child, an incredibly rare diagnosis. Now, fortunately for me and the child and the surgeons, this is, I think, possibly the only, I'm sure somebody can correct me if I'm wrong, but it's a type of lymphoma for which, thankfully, surgical resection is recommended. Obviously, normally you wouldn't want to resect a lymphoma in the diffuse large B-cell lymphomas that we see in adulthood, but this one, thankfully, was best treated with surgical resection and then adjuvant chemoradiotherapy, and I understand the child's doing very well. Okay, so I hope you're all still with me and following along. I'm sorry, I like to have the feedback from presentations, but I'm sure we'll get that in due course. Now, we're used to in neuropathology, neurosciences, neuro-oncology to have particular presentations, and one of those is the optic pathway glioma. So here, this is a 3-year-old boy presented with unilateral visual loss and the squint, and on the presentation, examination was found to have a pale swollen optic disc. So here are some MR images, T2 MR images, one from August, one from November, following November, so 2 or 3 months later. And you can see here that there is a tumor in the optic nerve. So this optic nerve is absolutely fine. This one is not. There's this sausage-shaped thing here. And between August and November, the plan was initially to do a short interval scan and see what happened. Often, if these things, well, very usually in a younger child, these things will stay quiet and not do anything nasty. But you can see in this image that it's starting to indent the back of the eyeball. And so the decision was made to give this child, this was on radiological grounds reported by several neuroradiologists, including those with an interest in pediatrics, to be an optic pathway glioma or parasitic astrocytoma. So the child had 6 months of the usual chemotherapy. And I'm sure you'll agree that this is now bigger, not smaller, and it seems to extend it back towards the chiasm. So a biopsy and then subsequent exenteration, actually removal of the eyeball and the entire optic nerve, was performed. And this is the optic nerve. So this is the perineurium here. So I've often only been able to take a small bit of it, but you can see that it is filled by something that really does not look like a parasitic astrocytoma. And on high power, you can see we've got these myxoid areas, not sometimes the vessel, but not always a vessel in the middle of them, surrounded by these cuboidally type cells. And this myxoid material is alcium blue positive, slightly epithelial looking in places, but I'll show you they're forming true rosettes, so flexion of intestinal rosettes, and actually a few homorite rosettes as well. So this is definitely not a parasitic astrocytoma. And it's a complex lesion. So you've got this more glassy, almost looks like gliotic CNS, gliotic retina. But this is in the optic nerve, it's not actually in the eye. And then these multi-layered structures, in addition to which there are these seas of primitive cells. So this is a very complex tumor. Here we go. Yes, a nice, almost a channel, a sort of a true rosette, certainly, and then a homoriot flexion of intestinal rosettes. Now, this appearance is very unusual, and one of the things we wondered is, could this be a germ cell tumor? Could it be an ATRT, an atypical teratoid rhabdoid tumor? Or could it be an ETMA, this is embryonal tumor with multilayer rosettes, which typically rise in the fourth ventricle? So we did Lin28A, so that control, you can see kidney, which is normal, but all of these things were negative, and which I mean, the INI1 test was negative, the stain was positive, but all the germ cell markers were negative as well. GFAP stained that gliotic material as you'd expect, but not the other components convincingly. A few CAM positive cells, the significance of which I'm not sure of even now. Some neurofilament staining, certainly particularly in those more, that the group in Heidelberg who are behind this fantastic bit of kit had been, as you'd expect, continuing to develop the maths behind the classifier. And what's come out of it is that tumors that we thought were one homogeneous group are obviously not. And there's one particular group of tumors that we happen to have had two of, which are Plag L1. In fact, I've just realized what a wonderful example of this it is, because one of our late colleagues, he's now in Manchester, was on this paper. Fantastic case of supratentorial neuroepithelial tumors that have this Plag L1 mutation. And they particularly tend to arise in children, relatively equal sex, slight male predominance so far, but the case numbers are small, and they are supratentorial. And one of the interesting things about these is that although they have a very typical methylome pattern to them, the authors comment, and this is our experience of them, is that there's a very wide morphological spectrum to these tumors. So you've got things that look a bit tanacytic, like a tanacytic ependymoma, really curious things. This would do very nicely for one of the subependymomas that you see around the lateral ventricle with microcystic change. And then we've got an oligo-like tumor here with pericellular clearing, so neurocytoma or oligodendroglioma, obviously not in children, but a whole range of different diagnoses possible from these. But all of these have the same methylome pattern. And to confuse you even more, particularly given that some of these look ependymal, is the fact that you can see EMA expression in a dot-like pattern. They tend to be OLIG2 negative, GFAP positive, so that too would go very much with this being an ependymal type tumor, but they don't appear to be so. They're defined by this Plag L1 aberration, and this is progression-free survival, and the numbers are small, but it does look as though this is not going to be a favorable tumor to have. So my purpose in putting this case in is to say that even though we have an amazing classification coming up, there are going to be other entities emerging as more tumors go through the classifier, and these small groups of tumors are allowed or become apparent as the classifier does its thing, and the good folk behind it. So more entities will emerge. We need to be prepared for that. What our clinical colleagues are going to be doing, I often give these nuanced diagnoses to our oncology colleagues, and they sort of shrug their shoulders and say, well, we've only got, a handful of things that we can target. We've only got a handful of therapies. And I feel very much so that we're, as pathologists, delivering increasingly granular diagnoses with incredibly complex molecular detail, but for which we're not sure yet either of the biological significance, or certainly how those can be actioned, how they can be treated for a better outcome for our patients. So in summary, pediatric CNS tumors are really tricky and complex, and with the best will in the world, we're all going to get them wrong every now and again. I feel tremendously more comfortable having the methylation arrays to support us in this, and as I've shown you, they can really help make a diagnosis in situations where you wouldn't otherwise have been able to do so. And reflecting that, they really are going to become essential in the new CNS WHO classification, along with the NGS panels and the fusion panels and so on. And even though it's complex already, I think it's going to get more complex, and hopefully that complexity will be converted into improved clinical outcome as we develop therapies, or more able colleagues than me can develop therapies to treat these things. So I thank you very much for your time, for your attention, and I'm sure I'll answer any questions one way or another. Thank you very much.
Okay, thank you very much, Dr. Simon. And this is, I think, the magnificent lecture on pediatric brain tumors. And there are a few questions, and I think you have already answered those questions. And I don't think so that there is any other question. Just people are praising you. There are signs of appreciation. And yeah, next year, I think we will invite you again for the, not for the pediatric brain tumors, rather than for the adult brain tumors, maybe. And I hope you will accept the invitation the next year.
I'd be delighted, yes. Thank you very much.
Okay.
It's been a pleasure.
Okay, thank you very much. Thank you. So now we have just reached the last lecture of today's second session, and the last lecture would be of Dr. Isabay, who is a consultant in Canada. He completed his PhD molecular biology in University of Alabama and molecular genetics fellowship at Mayo Clinic, Rochester in USA. Currently, he's an associate professor at the Department of Lab Medicine and Pathology in University of Alberta, and molecular pathologist and scientific lead at the Molecular Pathology Laboratory at Edmonton, Alberta in Canada. His research is focused on the molecular mechanism of cancer and the use of genomic technology in disease diagnosis. He has multiple abstracts and publications. His lecture is about molecular pathology of lung. And now screen is with Dr. Isabay.
Hello, I'm Yari Zebaye, a molecular pathologist at the University of Alberta Hospital. And my talk today is molecular pathology of lung carcinoma. This is an outline of my talk. The introduction will be given, then followed by case presentation and an overview of next generation sequencing, the molecular basis of lung cancer, targeted therapy, mutations in lung cancer. Then I'll talk on cell-free circulating tumor DNA, immunotherapy of lung cancer, and practical considerations for the lung pathologist, and then I will conclude. Lung cancer is one of the most common cancers in the world. There are 2 million cases annually with 1.7 million deaths. Majority, 8 to 85%, are non-small cell lung cancer, further subdivided into adenocarcinoma, squamous cell carcinoma, and large cell carcinoma. The management of these diseases have been transformed in the last 10 years by a number of developments, including a better understanding of the molecular basis of non-small cell lung cancer, advances in genomic technologies, next generation sequencing and bioinformatics, and emergence of a wide range of targeted therapies against mutations in lung cancer, as well as the emergence of immunotherapies against checkpoints. So this was a 74-year-old woman without prior history of smoking, hospitalized for pain in the lower right chest wall. A CT scan showed nodules in the right lung, mediastinal lymph nodes, liver, and pleural surfaces. biopsy was done, which returned a morphological review of lung adenocarcinoma. Molecular testing was done. The initial resulted in a mutation detected in EGFR L858R, and subsequently with resistance, it was repeated and there was detected a T790M resistant mutation. The clinical diagnosis was stage 4 lung adenocarcinoma made in September 2016. She was prescribed gefitinib for 7 months, and when she developed resistance to this, it was switched to osimertinib. She had stable disease for 1 month, and then progression resulted for 3 months, for which she was placed on pemetrexed for another 2 cycles. This had to be discontinued due to GI intolerance. She had a microwave ablation of the liver. A repeat CT scan in 2017 showed enlarged pleural nodules. She had exon sequencing, and this showed a low tumor mutation burden of 2.49 mutations per megabasis and low tumor neoantigen burden of 1.5 neos per megabasis and positivity for HLA-LOH. She received low-dose decitabine plus camrelizumab every 3 weeks for 7 cycles. And she had a dramatic improvement in her mediastinal lymph nodes and the liver and pleural nodules, which shrunk after 2 cycles of combination therapy. Pain in the right lower chest wall was also improved after 2 cycles of treatment. However, after 7 cycles, there were enlargement of the right lung and pleural lesions as detected by the lung CT. And because of this, she had to discontinue the low-dose decitabine and camrelizumab as a result of the disease progression. But it was noted that during combination therapy, the TMB levels had increased. Also, the tumor neoantigen burden decreased from 1.55 to 1.32. Her MSI-LA, HLA-LOH remained unchanged. Subsequently, she complained of moderate fatigue, grade 2 fatigue, and grade 2 vomiting was diagnosed. Unfortunately, she succumbed to her disease in 2019. So an overview of NGS, that's also known as massive parallel sequencing, and there are 4 main steps. The DNA is fragmented and massively sequenced. The sequences are aligned using bioinformatics and computation, and the alignment is compared to a reference sequence, and the variant interpretations are made. Subsequent, the meaning of these variants, that's variant annotation and clinical interpretation, is done. Variants are divided into 3 categories: benign, variants of undetermined significance, and pathogenic mutations. In contrast to traditional molecular methods like PCR, FISH, Sanger sequencing, NGS enables the interrogation of multiple massive numbers of targets in a single assay. Numerous applications also exist, and this could be targeted sequence, where you restrict what you are looking for to a large number, but fairly small compared to the whole genome or the whole exome. Whole exome sequencing can be done, like was done in this particular patient that we discussed. Whole genome sequencing is also another application. RNA sequencing, and this is useful for gene expression studies, and most importantly for our discussion, gene fusion detection. All these applications have been used to benefit in molecular diagnostics of lung cancer. To give an overview of the molecular basis of cancer in general, in 2011, a landmark paper by Hanahan and Weinberg discussed the hallmarks of cancer. And they identified a number of important characteristics of all cancers generally, including sustaining proliferative signaling, evading growth suppression, avoiding destruction by the immune system, enabling replicative immortality, promoting tumor inflammation, activating invasion and metastasis, inducing angiogenesis, genomic instability and mutation, resisting cell death, deregulating cellular energetics. And I think I mentioned sustaining proliferative signaling as the first one. Now, these hallmarks are listed in the inner circle, and outside the circle are specific classes of drugs that target each biologic feature of that particular cancer. And so the general thinking in cancer biology is to move away from a shotgun mechanism of therapy to one that is directed against specific biologic features of the tumor. And this same principle is very applicable to lung cancer. And this is a molecular biology of lung cancer. Mutations in oncogenes and tumor suppressor genes result also in uncontrolled proliferation, reduced apoptosis, local invasion, angiogenesis, metastasis, and immune invasion. And these features at the cellular physiologic level. Going down into the molecular level, you can identify a signaling pathway that drives any of these processes. And we will use EGFR signaling pathway as a template. And so you have a ligand, the EGF binding to the EGFR, which is on the cell receptor. And on binding, the signal is transduced into the intracytoplasmic region, where the tyrosine kinase activates two important pathways for the EGFR signal transduction mechanism. One pathway is the RAS-MEK-MAP kinase pathway. The other is the PI3K-AKT pathway. And you can also have STAT signaling. And when these pathways are activated, downstream gene transcription occurs and cell cycle progression, leading to proliferative pathways like resistance to apoptosis, metastasis, angiogenesis, invasion, or proliferation. And this is a normal cell physiologic mechanism, but when mutations occur in any of these pathways, it produces a constitutively active signaling pathway such that it now becomes independent of upstream signaling, and there is sustained growth or proliferation of any of these downstream processes. The types of mutation in lung cancer include a single nucleotide variant, when a single nucleotide is substituted to another that results in a pathogenic oncogene. You can have small insertions and deletions, copy number variations, where you have more genes than physiologically normal in a cell. And a good example is amplification, and we know about HER2 amplification in breast. That same process can also occur in lung cancer. You could also have gene fusions, where two normal genes are brought together to produce a single new gene through some chromosomal instability process, and that new fusion gene has oncogenic properties. And these are a list of genes, mutations, and the frequency that occur in lung cancer and squamous cell cancer, and they include the classes we described, CNVs, SNVs, and gene rearrangements. And they are quite a large number. We will take the most important ones and discuss in subsequent slides. This is a pie chart showing the incidence of the mutations in lung cancer. KRAS tends to be the highest with 32%. EGFR is constitutes 11.3%. And these are other fusion genes with their various percentages. I will just highlight some fusion genes like RET fusion, that is 0.9, ALK fusion, that's 1.3, ROS fusion, that's 1.1. Also, MET exon 4 skip lesion is also fairly high, 4.3%. We should note that these frequencies of mutation is what is found in the North American population. In other populations, the proportions may be different. For instance, we know that in Asian population, EGFR frequency can be as high as 40%. Now, knowing the mutation type and gene that's present within the cancer cell can, direct and aid the use of small molecules that target those particular mutations and inactivate their property. And so in the signaling pathway for EGFR, you can have a targeted, small molecule inhibitor. And then you have the two pathways, the KRAS, BRAF, MEK pathways, and each of them have their targeted therapies, same thing as the PIK3, AKT pathway. And so you have EGFR HER2 inhibitors, BRAF inhibitors, PI3K inhibitors, and so on and so forth. And inhibition would also result in inhibition of their downstream effects like cell proliferation, angiogenesis, and metastasis. Now, despite using small molecules to inhibit the activated protein, the cancer cell can still utilize resistant mechanisms to overcome that inhibition. The most common resistant mechanism is a mutation within the same EGFR gene when an EGFR tyrosine kinase inhibitor is used, and that's the EGFR T790M mutation. It occurs in up to 50% of resistant mutations. Other important ones include the MEK amplification, HER2 amplification, small cell transformation, EGFR C797S mutation, osimertinib, that's when you use the drug osimertinib against a T790M, or mutations in the BRAF PTEN gene. This is a mechanism of secondary resistance and therapeutic inhibition. Usually you have your initial clones and you target it, you treat it with the EGFR inhibitor. And usually there is a very small number of cells that have the T790M right at the start. But when you use this drug, it gives those cells a survival advantage because there's selective pressure against the other cells and for them. And so there's an overgrowth of, and they become the predominant cell types in the cancer. You could change the drug to one that targets the T790M like osimertinib, but then a mutation, the cells within that initial population that have that small fraction of, a small fraction of cells with the C797S that's resistant against osimertinib also would gain a growth advantage and proliferate and become the predominant cells. Once you've run out of targets and available drugs, you switch over to traditional chemotherapy. Unfortunately, this is also limited and tumor progression results. And this is just one mechanism of resistance. There are other mechanisms of resistance that bypass, use methods besides what I've described to bypass, and the same process results. And so now let's discuss various genes and their mutations. EGFR, as we mentioned, is the most common mutation that has a targeted therapy directed against it. As we mentioned, in the North American population, the frequency is about 11%. In the Asian population, it is higher, 45%. There's the characteristics of the type of patients that tend to have EGFR, and we typically describe them as young, female, and Asian. However, other population groups may also have that, the EGFR mutation. So clinically, you do not use those characteristics. Common alterations include the 21L858R mutation and the exon 19 deletion. These two mutations constitute greater than 50% of all EGFR mutations. Others include exon 18 and exon 20. It's important to also note what type of resistant mechanisms can occur. You can have mutations within the EGFR gene itself, like the T790M, the C797S. You could also have exon F, EGFR exon 20 insertion. This is typically a primary resistant mutation as compared to the others, which are secondary resistant mutations after institution of therapy. Other mechanisms, small cell transformation, secondary fusion events, copy number alterations in other pathways, P53, PIK3CA, KRAS cell cycle can also occur, and are listed the available targeted therapies. And this is the EGFR gene, which has multiple domains, and the most important is the tyrosine kinase domains, which extends from exon 19 to exon 21, where most of the primary activator mutations occur, and also the T790M resistant mutation occurs. BRAF is also another important gene. The important mutation is V600E mutation that you see in other conditions, but you can also have non-V600E mutation. Resistant mechanisms include the MAPK signaling reactivation, EGFR signaling, and elevated YAP1 expression. They are also available targeted therapies. ALK fusion occurs when there's a deletion in the region intervening the ALK and the EML4, and these two genes are brought together to produce a new fusion gene that has oncogenic properties. EML4 is not the only gene that can result from fusion with ALK. ALK may have multiple other fusion partners. It also has secondary fusion, secondary resistant mechanisms like mutation within the ALK gene itself. ALK copy number may increase, or there may be alternative pathway activation. You could also have small cell transformation. Listed here are available targeted therapies. The ROS fusion gene is also very important in lung cancer. You could have multiple fusion partners. Mutations within the ROS1 gene also can produce resistant mechanisms, as well as off-target mutations in TP53. Available targeted therapies are listed. The MET proto-oncogene receptor tyrosine kinase can produce an oncogene when there is a skipping mutation of exon 14. MET amplification can also occur and lead to oncogenesis. RET fusion occurs most frequently with the KIF5D gene. You could also have multiple fusion partners, resistant mechanisms using the same principles, mutation in the RET genes, or activation of other pathways like EGFR, AXL that lead to bypassing of your inhibitor. There are also available targeted therapies. NTRK, you could have NTRK1, 2, or NTRK3 gene. There are multiple fusion partners for each of these. NTRK is an interesting fusion gene because it can occur in any cancer in the whole body. Resistant mechanisms include IGF-1R and various NTRK mutations. Available therapies are listed. The HER2 can also occur, and oncogenesis results from exon 20 insertions or exon 20 duplications. Resistant mechanisms include mutations within HER2 gene itself, or PIK3CA mutations, HER2 copy number gains, or other off-target alterations. And available therapies are listed. And I must mention at this point that those genes which I've just discussed are those that have well-defined, established, and approved targeted therapies. There are other genes that are crucial in the oncogenesis of lung cancer, but do not at this point have approved targeted therapies. Now, these mutations may play a role in resistance or may impact prognosis. And so they are useful overall in, it's good to know, excuse me, it's good it has been used in clinical therapy. But genes like TP53 and others are also crucial and important for oncogenesis. And these are other genes which I've listed. And I'll just not spend too much time on it. I will go on to cell-free circulating tumor DNA. And this important concept refers to the fact that cancer cells, during the process of degradation, releases small fragments of DNA into the bloodstream at very, very small levels. Now, if you take a blood sample and use highly sensitive methods, you may be able to pick up this mutation, DNA fragments. And it's also impossible to assess what mutations are present in these fragments and correlate with the primary tumor or the metastatic lesion. This concept of circulating tumor DNA, which is also known as liquid biopsies, has numerous applications in lung cancer, including early diagnosis, real-time monitoring, progression, drug resistance, minimal residual disease, and immunotherapy. And on this panel, it illustrates how this can be done. For instance, if you are screening a patient that you highly suspect for having lung cancer, or you highly anticipate a recurrence, you can monitor the levels of ctDNA. Rising levels suggest that there is a mutation. Rising levels suggest that there is a cancer. And if you also pick up mutations that you expect in that cancer, then you can make a diagnosis of your lung cancer. Surgery can be done. After surgical intervention, the level should fall, and you can monitor the falling levels to determine how extensive or how complete your surgery was. And then you can also continue monitoring to see whether there are rising levels. Rising levels suggest that the disease is progressing. And when the disease progresses, you can administer, if you detect a mutation, you can administer an inhibitor against that mutation, and then further monitor the response of the tumor to that targeted inhibition. And you should expect the tumor levels to also fall. Once they begin to rise again, it suggests that drug resistance may have taken hold. And then you can also analyze for the presence of drug resistance. And if drug resistance is present, then you give a rise again. It suggests that there is resistance to that drug, and then you can now change therapy. You can use immunotherapy. You could use whatever available drugs are present and keep on monitoring. We're at the point where ultimately resistance will develop to all available drugs, but hopefully things will change with time. Another important concept is immune checkpoint inhibitors. The immune checkpoint is a normal physiologic response in the human body, to regulate or turn off the immune response. And the whole point is that the T cell acts against an invading organisms to neutralize or to kill it. And after its job has been done, you need to shut it down so that it does not continue to kill the normal human cell. And so the normal cell produces a PD-L1 which binds against PD-1 on the T cells and causes a switch. The signal switches off the activity of the T cells and protects the normal human cell from being killed. Now, the cancer cells can utilize this same mechanism to evade the immune system by expressing PD-L1. And so when it encounters a T cell that actually comes to kill it off, it shuts off the activity of the T cells. And so it survives. However, if you create a molecule that blocks either the PD-L1 or the PD-1 or the PD-L1 and prevents that interaction, that handshake, you prevent the shutting down of the T cell, or you shut on the T cells, and that allows the T cells to kill the cancer cells. And that's the whole concept of immune checkpoint inhibitors. Now, not all cancers utilize that particular mechanism to evade the immune system. And so the oncologist or the treating physician has to determine whether that particular cancer or which cancers would respond to immune checkpoint inhibitors. And there are three biomarkers that are currently established for this process, and that's PD-L1. And PD-L1, of course, is the protein that turns off the immune system. And so if it is present in significant amounts, then it's likely to mean that that cancer will be responsive to the checkpoint inhibitors. PD-L1 is assessed by is quantified by immunohistochemistry, and there are cutoffs to determine positive or negativity. Other markers include tumor mutation burden, and this represents the total amount of mutations present overall in the cancer genome. It is measured by counting each mutation and dividing by the total number of megabases. High levels imply there is a high mutation rate. Now, if there's a high mutation rate, it means that there will be a higher number of abnormal proteins or neoantigens, and neoantigens will trigger off an immune response. In other words, the particular cancer will be very immunoreactive, and this level can suggest that immune checkpoints will work because you have a very active immune system. Microsatellite instability also results in high levels of mutations, and so you could use MSI to monitor, use MSI as a biomarker. And if there are high rates of, if the MSI level is high, it implies you will also have high new antigen that would trigger off an immune response. Now, these are practical considerations for the pathologist. And the first one is tissue conservation, and as we've seen, there are increasing number of targets to be analyzed for therapeutic intervention or for prognosis. But then the biopsies we receive are getting smaller and smaller and smaller, mainly for patient convenience to avoid morbidity and mortality from invasive procedures. And so because we have very small biopsies, and the most important thing is the right therapy, in making a diagnosis, you ought to use a limited IHC panel rather than an expanded panel to rule out all the possibilities. That's important, but the first consideration is tissue conservation. And if you have multiple cores, you place them in separate containers so that one can be dedicated to molecular. Upfront cutting to avoid repeated refacing and wastage of tissue each time you have to go back into the block. It's important to have an assay that can test myriads of targets, that's known as multiplexing. Rapid sign-out reflex testing by the sign-out pathologist ensures that there is a quick turnaround time such that you cut out the lag time between sign-out and the oncologist ordering. And so the pathologist plays a crucial role in initiating the molecular testing. Rapid turnaround time of 10 working days is advised for the molecular lab so that because the median survival of untreated patients is 16 weeks, and you don't want to spend more than 2 weeks just doing testing. If you need to do repeat testing, the non-invasive circulating tumor DNA or liquid biopsy is a very, very good alternative to invasive biopsies and procedures. This is a suggested triage of lung biopsy samples, and so as I mentioned, multiple cores should be placed in separate cassettes. So you advise the oncologist or the biopsying physician to take multiple cores. And when the pathology makes his assessment on light microscopy, he has to decide whether there's limited tissue or sufficient tissue for further downstream testing. If there's limited tissue, then of course you make sure your IHC is limited to P40 and TTF1. And then you should also order PD-L1 for immunotherapy. Of course, if the tissue is small, and depending on the equipment your molecular lab has, you may either choose to do a limited panel because you just have small quantity of DNA. You may do ALK-ROS IHC as a surrogate or for screening. If you have sufficient tissue, then you could consider, especially for polydifferentiated tumors, what IHC panel to use, you could expand it just a little bit. And you could also do expanded, more comprehensive molecular panels because there are different instruments. Some instruments are amenable to very, very small amount of DNA. Others can handle larger amount. So the pathologist should be acquainted with the workings of the molecular lab and make the triaging process fit to the local situation. Now, with the knowledge we have on our fingertips, we can review our case we discussed. So this patient had both primary and resistant mutations. The initial primary activating mutation L858R was treated by gefitinib. Afterwards, she developed a resistant T790M mutation, and that was prompted alteration of her therapy to osimertinib. She then still developed resistance. Now, she wasn't tested for what the resistant mechanism was, but it's most likely C797S mutation. However, she was tested to see whether she would be responsive to immune checkpoint inhibitors, both by tumor mutation burden and MSI. The results came out to show that she had low levels, which would suggest that she wouldn't be responsive. But then the oncologists decided to add another drug that may alter the tumor mutation burden and raise it to a level where it would be responsive. Now, that's an experimental process, is an experimental drug, but he's at liberty to do that. And he proceeded to treat her with immune checkpoint inhibitors. And subsequent monitoring of the tumor mutation burden showed that the levels did arise, and that's why she was responsive to the checkpoint inhibitor, although eventually she developed resistance and succumbed to the disease. But it showed a number of interesting things. And the first is that the time from diagnosis to death was markedly improved from what we usually expect. It was 3 years for her. In the past, it was much less than this. And we could also see how multiple molecular testing throughout the course of her therapy guided the treatments so that adjustments could be made for the primary, the secondary mutation, and the tumor mutation burden. Guided the therapy, was enabled her progression-free survival by because it was monitored to the testing and to her the biologic process of her disease. And this case shows how there has been marked improvement in the management of lung cancer, how management of lung cancer is being transformed by recent advances in genomic technologies, high throughput sequencing, and then the availability of new treatments like targeted therapy and immunotherapy, and an improved understanding of the molecular basis of lung cancer. And this somehow summarizes the goal of precision medicine, also personalized medicine, in which therapy is guided by the unique biology of the underlying disease and the patient's characteristics. And the goal of personalized medicine is that one day cancer will be transformed from a lethal disease to a chronic manageable one. And these are my references. Thank you for listening.
Okay, thank you very much, Dr. Izabai. And the first thing is, I'm really very sorry because since time is not very civilized there in Canada, it's right now, it's very early in the morning, and you are 11 hours behind us. The second thing is, it's a magnificent lecture. It was a detailed, and there was so much detail that there are few people who are, I think, shocked by your excessive detail. So there are many questions, but I think you have answered all the questions, and there's only one question left for you. The question is, as far as MMR pathway of lung cancer is concerned, please tell us if the MSI IHC is a good surrogate marker as it is clonic carcinomas.
So yeah, thank you for that question, and thank you for having me to give this talk at your symposium. So the answer to that question is yes. Typically at this point in time, MMR IHC is an extremely good marker for MSI instability, and we still use it as the first line test for MSI. and not only in lung cancer, but also in other cancers that are candidates for immunotherapy. You could also use molecular techniques against MSI, but MMR is a very good marker.
Okay, thank you very much for the participants. The questions and answers are present in the QA box. You can go there and see the answers of all the questions. So once again, Dr. Izabai, thank you very much for your participation in this symposium, and hopefully we'll invite you again in the next year. Hopefully.
You.
Yep.
Thank you.
Thank you very much. Thank you very much. So this is the end of pathology sessions of this year's symposium. So this was the last lecture, and I hope all of us must have learned a lot through these magnificent lectures. At this time, I must appreciate all attendees who are real essence of this learning activity. Excuse me. And relentless efforts of entire IT department. Without their help, this entire virtual academic activity will remain elusive. Moreover, I cannot forget Anika's efforts in making every symposium a success story. Symposium chair, especially Dr. Asad Pervez, co-chair, my whole pathology department, who helped me selecting and inviting speakers, including Dr. Sajid Mushtaq, our HOD, Usman Hassan, Dr. Mariam, Dr. Asad, Dr. Umar, and Dr. Tariq. And at the last, this list will never be completed without naming administrators of this magnificent institution, Dr. Asif Loya and Dr. Asim Yusuf. Thank you very much. And hopefully we'll join again in the next year. Thanks for and goodbye.